Welcome everyone to our first live webinar on TriClip therapy. My name is Sarah Johnson. I'm a product manager at Abbott Structural Heart. We have hundreds of interventional cardiologists and echocardiologists on the line today. And as you all know, tricuspid transcatheter edge-to-edge repair is so critically dependent on imaging and on the imager. So we have brought together experts from two highly experienced centers to discuss this very important topic: how to leverage your imaging toolbox for TriClip therapy. I'm pleased to introduce our expert panel of presenters. Dr. Gagan Singh is a professor of medicine at the University of California, Davis Health System in Sacramento, California. He is an interventional cardiologist and serves as the Director of Structural Heart Interventions and the Cardiovascular Research Unit. His clinical and research interests include implementation and development of catheter-based therapies for the treatment of valvular heart disease. Dr. Edris, also from UC Davis, completed his residency, fellowship, and advanced imaging fellowship at UC Davis Health. He is now Associate Clinical Professor of Cardiovascular Medicine and serves as Director of Interventional Echocardiography and Director of the Advanced Cardiovascular Imaging Fellowship. When he's not in the cath lab with Dr. Singh, he spends most of his time with his daughters, who are 3 and 4 years old, going to Disneyland too many times to count. Dr. Lucy Safi is an assistant professor of medicine at Icahn School of Medicine and currently works as a structural heart imager and interventional echocardiographer at the Mount Sinai Hospital in New York City, one of the highest volume sites for TriClip interventions in the US. She completed her cardiology fellowship at Cooper University Hospital and advanced echocardiography fellowship at Massachusetts General Hospital. Dr. Safi has been an active member in the American Society of Echocardiography and currently serves on the ASC Board of Directors. Both UC Davis and Mount Sinai participated in the TriLuminate pivotal trial, and they were among the very first centers in the country to treat patients with TriClip shortly after we received FDA approval. We are so pleased to have their wealth of knowledge and experience with us today. Here's our agenda for this evening's program. Dr. Singh will give us an introduction to the TriClip system and a recent case study to bring it to life. Dr. Safi will then take us through the necessary TE views and cover her best practices for using MPR and ICE for TriClip procedures. Then Dr. Aman will spend some time showing us how to optimize your imaging for a critical part of the case, grasping and leaflet insertion. We'll then open it up for a Q&A and a panel discussion. Before we get started, just some quick housekeeping reminders. This webinar is being recorded and will be available for on-demand viewing. Questions can be submitted at any time through the Q&A feature on your screen. And you will be receiving a survey shortly afterwards, and we would really appreciate your feedback on the program. I'll now hand this over to our first presenter, Dr. Gagan Singh, to introduce us to TriClip.
Great, thank you, Sarah, and welcome everybody joining us all the way from the East Coast to the West. It's about 5 o'clock here in California, obviously a little later in the East Coast, and we thank everybody for joining us. When Sarah approached us maybe a few weeks ago, a few months ago now, to talk about this webinar, I think it's so important. This really is the beginning of the journey for all of us. It's for implanters, for imagers together. And I think having sessions like this are critically important. And these are not just designed for imaging folks. These are not just designed for implanters. It's really the boundaries between who's an imager and who's an implanter really should be blurred now. It's not so definite anymore. As an implanter, I've learned so much from my imaging colleagues, and our imaging colleagues have learned so much about the device from the implanters, where cohesively, as we go through these cases, we're speaking the same language. And so hopefully the next hour kind of highlights that for you. And I'm thankful to be joined by this great faculty here, and thankful to Sarah and Abbott for hosting such an important webinar. So with that, we'll kind of get going, and then I'm just going to get into the meat of it. And talk a little bit about TriClip and the journey of TriClip really briefly over a few minutes, and then get into a case just to kickstart things. So clearly, the tricuspid therapy TriClip device is really built on the legacy of mitral TEER, and not just initial kind of benchmark studies or short kind of patient studies, but really built on a CE mark study, then pivotal trials, and then since then multiple post-approval studies, and now we continue to garner greater interest and greater publications coming out, not from just the United States, but EU as well. And then of course there's many non-industry sponsored registry data that collectively continue to talk about the safety and efficacy of the system and the therapy, and we'll briefly touch upon that as we go. The device itself, really briefly for the folks who have not had their hands on the device, if you've used the MitraClip system, the back part of the device where it actually deploys the clip and grabs the leaflet, the business end, which is right here, is all about the same. That's kind of maintained the same. However, if you look at the guide catheter and the clip delivery system, as I've highlighted here, those two have changed a little bit, and really to allow steering directly down to the tricuspid valve, and also to help move away from the interatrial septum, and to allow treatment. At the distal end of the guide catheter here, everything has been shortened to get these clips and to get the specific implant down to the valve with much ease. And so really the whole system is designed specifically for the tricuspid valve. And for those of us who've been fortunate enough to use it, I can guarantee you that this has been a remarkable achievement in allowing us to treat these patients. As Sarah mentioned, I think the approval of this device, not just as the approval of the device, but it really acknowledges the therapy for the space. That tricuspid edge-to-edge approximation, tricuspid regurgitation, is an important treatment option for these patients. The FDA panel voted unanimously that it was safe, and again, this is credit to a lot of the sites that were involved in the clinical trial. And then we had signals of effectiveness, and of course, there's a benefit to risk profile, and we were really honored, along with Mount Sinai and Minneapolis Heart Institute to be one of the first ones in the country to be able to treat our patients commercially. And of course, since then, there's been a relative explosion, and not just interest, but in the patients that are coming forth asking for help, and also for us, for the patients that we're treating, as we treat them, because now, not just in the trials that have been published and presented to the FDA, but even since then, we continue to see recurrent signals of improvement in quality of life. We see that it's effective in reducing TEER, and of course, the safety profile is available as well. So with that in mind, let me quickly get into a case, and again, I'm going to leverage heavily on Lucy and Edris to really kind of teach us about the imaging components. And as just a implanter here, I'm going to kind of use a lot of the images that they provide us and show you kind of the thought process of approaching a case such as this. So this is a prototypical patient with tricuspid regurgitation, 83-year-old, and they have class 3 heart failure symptoms, which are not the same symptoms that we see with mitral insufficiency. A lot of these patients have fatigue, exercise intolerance, abdominal fullness. Some have lower extremity edema. It is not uncommon for these patients to have permanent atrial fibrillation and chronic kidney disease. But really the mainstay for the treatment for these patients is medical therapy, which consists of diuretics, mineralocorticoid receptor antagonist, and an SGLT2 inhibitor if they can tolerate and afford it. These patients have a series of laboratory markers, and perhaps most importantly, they have hemodynamic assessment with a right heart catheterization, as shown there at the bottom row, to really confirm that their TR is independent of any sort of left-sided disease. This is critically important, as we've learned from the clinical trials and historically, that the left side pathologies are adequately treated before we attempt to treat the right-sided disease to help really get the best benefit in improvement in quality of life and reduction in TR. So in this particular patient, we always start off with a screening transthoracic echo. We confirm that there's an absence of left-sided disease. We really confirm the severity of the tricuspid regurgitation. This particular patient has a large right atrium and minimal right ventricular enlargement and dysfunction. And in this particular case, we have no pacer leads. And so that in itself is a whole, maybe a several-hour webinar on how to approach patients with pacemaker leads. But the clinical trial has shown that it can be done, and it can be done very safely and effectively. So often we'll see a deep esophageal zero view first, and really that in a transesophageal setting tells us that there's significant TR, the right atrium is enlarged. I don't see pacemaker leads here, but from how to approach this patient from a procedural standpoint, it doesn't really help me as an implanter much in terms of how I might technically approach this patient. Really, this is kind of one of the mainstays, this mid-esophageal RV inflow view, which I have to give credit to all the imagers across the world that are able to get a really good mid-esophageal inflow view such as this. It can be challenging, and Lucy and Edris can hopefully give us pointers on this. But it really gives us the direct line of sight to the tricuspid valve. And this can be very challenging. No matter how hard you try, sometimes you have to penetrate through the left atrium, the septum, the annulus to get to the tricuspid valve. And so there can be a lot of shadowing, but if you can get behind the right atrium, this helps us. And then our imagers will do something called an X-plane march. So in this side, you see that the X-plane cursor is sitting a little bit closer to the aortic valve. So we call that a little bit aortic. And then they'll start moving that cursor and closer to the IVC, or caval or posterior, whatever terminology you want to use them. And that way we see exactly where the tricuspid regurgitation is originating from. Multi-planar reconstruction, and whether it's NPR from Philips or the other manufacturers, whatever you like to use as your imaging modality, all of them have access to NPR. It's very important to understand that how to map the tricuspid valve, to map the specific leaflets. We've always thought the tricuspid valve is a tri-leaflet valve, and from work done by Becky Hahn and others, we know that that's true maybe 50% of the time. The rest of the time, there's more than one leaflet. There's many scallops. There's a very complex, intricate subvalvular structure. But this NPR system that's generated puts the inflow view on the top left. We have our grasping view on the top right, and then kind of a short axis or a simulated transgastric, if you want to call it, 2D view on the bottom left. And of course, you have your 3D. And this probably ends up being the most accurate way to assess leaflet length and gaps for your patients. And so and again, one of the other important views is this view, the transgastric view. And working on this takes a lot of time and a lot of energy. And this really allows you to see the tricuspid valve in its short axis. And if you can see the image on the right, what I've done is I've taken just a still image and shown that when you pause the valve in systole, you can make out the different leaflets, the septal leaflet, the anterior leaflet, and then the posterior leaflet back here. This is really what allows us to, again, as we're reviewing screening images, to come up with a procedural plan on how we're going to target it. And then when you put color on, you can see where the jet origination is. With tricuspid regurgitation, we don't really care about where the TR is going or how big it is, but certainly how big it is, but what we really care about where it originates from, because if you can target the origination with an implant, with a TEER system, with a TEER device, and I can tell you that if you target where the jet origination is, that will take away the bulk of the TR, and so it becomes important. This clearly is a little bit complex. If you look at the image on the right, I've again frozen it at systole, and you can see that it's originating from the septal anterior segment, a little bit from the anterior posterior, and also a little bit from the septal posterior segment. So if we can kind of draw a diagrammatic strategy here, the red parts here represent where the TR is originating from. Our imaging is satisfactory. The patient is well compensated based on the hemodynamics. The leaflet lengths are long, especially in that septal anterior segment where our first set of clips are going to go. Per the clinical trial, we always wanted to target 2+ or less, but our target is always as low as possible for all these strategies. So our clipping strategy, as I sit down at the beginning of the case, review with Edris and some of our other imagers, what we might target was, we might try to put 2 XTWs here in between the septal and the anterior leaflet, and then 1 in the septal posterior segment to allow for the greatest amount of TR reduction. So the clip gets brought in. After the clip is brought in, this is XTW number 1. We do our trajectory assessment here under NPR, and we position it in the appropriate place. We'll do our alignment as well, which we talked about. And as you go through these panels, number 1, 2, and 3, and 4, and this is just under X-plane, what you're seeing is that the clip is being advanced until it is just below the leaflets here, as you can see right there where I've highlighted. The clip is just below the leaflets, the arms are opened, and then the arms are pulled back to engage the leaflets. And at that time, what we will do is we will switch to a transgastric view. And in the transgastric view, what we're doing is we're slowly pulling the clip system back. And as it's coming back, we're trying to identify the leaflets, the septal leaflet, the anterior leaflet, and then the arms as they're open. And once the arms have engaged the leaflets, then it's time to actually drop the grippers and close the clip arms. And what we generally will do is after we've kind of engaged the leaflets, we will confirm in dedicated 2D view, but we will also switch to a series of different modalities to confirm that the grippers have come down and engaged the leaflets, and then we close. So this can be done in transgastric itself. You can generate an NPR, and I'm positive that Lucy and Edris will kind of talk about the advantages of generating NPR from the transgastric view. There's certainly advantages, disadvantages, and then we'll also go to the mid-esophagus and do the exact same thing. See the grippers come down, close, and make sure that we have adequate leaflet insertion. So in this particular example on the right image, I can see that there's adequate leaflet insertion in the short axis view. And then down here, what I see here is that the anterior leaflet is up and over the leaflet arms, but there's a fair bit of shadowing here on the septal side, and we don't necessarily see that. And that's kind of what the text here essentially highlights. But then you go back to mid-esophageal view, and then when you look at the mid-esophageal view there, I can see the septal leaflet is very well inserted. And in this particular view, Edris can kind of move the X-plane cursor both in and out of the clip to confirm that we have adequate leaflet insertion. And with that alone, and it's amazing how just one implant in a case like this, and if you look at the image on the left is what we started off with, in real time, as soon as we put that first clip on, we saw a pretty dramatic reduction in the tricuspid regurgitation. So there is still some origination here centrally. And so the question is, do we want to put an additional clip on just a little more adjacent? And this is a little bit an advanced technique here. And I just want to highlight this real quick. If this is the NPR plane that's built in the transgastric, the blue plane, which is hard to see maybe on the webinar, is just kind of identifying the area just adjacent, just a little bit more central to the clip that we just placed. And we see this very concerning but beautiful subvalvular architecture. You can see on the bottom left, these papillary muscles, that's a highlight right there. That's another highlight, papillary muscles. And then as with the breathing, you can see these cords come in and out. And so this is something that we've learned to use to avoid cords, to basically, we know that this is an area we're probably going to stay away from a TEER device. There's not enough landing zone, but also the chordal structure. And so perhaps we want to just target our next clip into the SP segment. And this is the thought process that we will generally have. And so here is clip number 2 as it comes in. We've opened up the arms. As the arms are opened, we do our alignment, we do our trajectory. And again, this 1-hour webinar does not replace all the training it requires. So I'm skipping through certainly a lot of the highlights, but just to the buzzwords of what we do to implant these devices. And now we go ahead and do our grab. And just like I talked about before, we look for the leaflets being engaged in the transgastric view. We'll try to look for the arms. We'll confirm our alignment, and then we'll go to generate an NPR or mid-esophagus to watch the grippers come down and the arms are closed. And then we kind of go back and forth. And as you go from the left all the way to the right, we are forming a greater tissue bridge in the 2D transgastric. It's the highest resolution. You can see both the arms and the leaflets. And it really allows us to get good insertion. And from there, we'll switch to NPR again. Again, you can see adequate amounts of leaflet insertion here on the septal leaflet, and there's adequate leaflet insertion on the posterior leaflet. And then we'll come back to the mid-esophagus. This is the mid-esophagus. We'll do it all over. And again, you'll see septal and see anterior. And after we're done with that, we'll kind of go back and compare. And this is what we've seen pre on the left, post after the first clip in the middle, and then finally after implanting the second clip, what we see on the right. We've taken the patient from 4 to 1 to trace. And philosophically, we can talk about the second clip, and I can tell you my own philosophical kind of rationale behind that second clip. But this patient just came in for their 30-day appointment and really is clinically doing fantastic. She's really done a great, remarkably clinically. She's gone from torrential amounts of TR, as you see here on the left, to really trace, and that's been maintained out to 30 days. And certainly we're seeing the clinical data come out of TriLuminate that if you can get them down to trace mild, that this is maintained all the way out to 1 to 2 years, and at least a 1-year follow-up that we've seen to date, which is very encouraging to see. So I'll close here by saying that, hopefully in a very brief 15 minutes, I highlighted a systematic pre-procedural imaging assessment, not just to demonstrate how much TR, but as an implanter and imager to come up with a technical strategy or technical approach to the valve. We certainly leverage the multimodality intraprocedural imaging, and as an implanter, it's important for me to understand what those tools are. And certainly I didn't get into ICE, my co-faculty here will get into the use of 3D ICE to help augment and to certainly, as an adjunct, certainly is critical, and they'll talk more about the features of that. And you have to be ready to adapt. There is no clear algorithm that every single patient is going to fall into. So one view may work for one patient, another view may work for another patient, and you have to be ready to adapt. And as a implant imaging combo, you have to kind of work together on that, and as you go through. As for the implanters, it's important not to settle for suboptimal imaging windows, especially during the most critical parts, which are the grasping and the leaflet insertion. And then imagers, you know, I mean, I know us implanters are very fidgety, and it's okay to tell us to stop moving so you can optimize the imaging window. And that's something that we do frequently. Edris will constantly tell me, oh, you're moving, so I'm going to stop moving. Or if he's moving, I'll stop moving to help kind of work through. So really, I think this hopefully highlighted to you the importance of this multimodality imaging, and just a brief snippet. And certainly we can spend hours talking about just one case alone. But this is hopefully a little bit of a teaser, and it really leads us into the next talk. So really a great pleasure to introduce Lucy Safi, who's done a remarkable job at Mount Sinai. And I've seen her do some live cases, and she really is a pleasure to watch and learn from. And so Lucy, if you could please teach us about TE views and NPR, I'd be forever thankful.
Oh, thank you so much. Very kind introduction. And I'm going to be talking a little bit about your TE views and some NPR as well. So I'm just going to jump right into it. These are my disclosures. And, you know, we're asked a lot as structural heart imagers to review cases to see if a patient's going to be eligible for a clip. And, you know, when you take a look at their TEs and you start in the mid-esophageal view and you're reviewing the TE, you may not know exactly what leaflets you're looking at. You know, it's very important to understand the anatomy when you're approaching cases like this. So, you know, depending on how much flexion or anteflexion is on the probe, you can be seeing either septal leaflet in the anterior leaflet or the septal and posterior leaflet. So really, one of my favorite views is this inflow view or the bicommissural view. And this view can be either 60 to 90 degrees in the mid-esophageal view. And it varies depending on how horizontal the heart is. You know, with right heart enlargement, you do have this right heart capability. And so what happens is when you're screening these patients, you want to make sure that when you're imaging to try to keep the tricuspid annulus horizontal. So here you can see, you know, the A and P here. And the annulus itself is pretty horizontal. So you know that when you're cutting with your biplane right through that anterior leaflet, you're seeing the septal and anterior leaflets on the orthogonal plane. And as you sweep through the tricuspid valve with your biplane and you go more towards the posterior leaflet here, you can see now that you're cutting through septal and posterior. So this is really one of my favorite working views, and one that I usually start with just to be able to map through the valve and see what you're actually working with. And if you don't have a good mid-esophageal view, if there's shadowing from, you know, prosthetic valves, or if there's lipomatous hypertrophy or atherosclerosis even in the aorta, you can have septal shadowing and you don't see that septal leaflet well. And so this is really where the distal esophageal view comes into play. And all of this is usually done right at the beginning of the case or even in the pre-procedural setting, and you document, you know, which are the best views. So the deep esophageal view, usually around 35 to 40 in the esophagus centimeters from the mouth. This view, you can really see the leaflets much more clearly. And if this is your view, then you can do this entire view for the whole case. And then lastly is your transgastric view. And this view in TEs is incredibly important. We just heard a great talk about how you can really see the origin of the tricuspid regurgitation from this view. And also, it's the only view in 2D where you can see all of the leaflets. And as mentioned previously, you know, only about half the patients really have 3 leaflets. Some of them have variants, whether it's 2 or 4. And this is the view really you can identify which leaflets are involved and where the TR really originates from. So when you're looking in the transgastric view, you want to make sure that you're flexed enough that you're actually at the tricuspid valve leaflet tips, and you can really see where that origin is. So after you've mapped, if the patient is on the table, you know, things you should do is always try to optimize your image quality before you start a case. And as an imager, these things have become just bread and butter to me. So you want to make sure your gain settings are appropriate. You want to make sure the patient is positioned properly. So you know in the cath lab or operating room, the patient is supine on their back. But what we do at Sinai is we always have a blood pressure cuff under the right shoulder, and we pump it up if we need to in order just to help approximate the heart to the esophagus and improve your image quality. You want to make sure that you're imaging a patient that's fully diuresed or as euvolemic as you can possibly get them. And then during the cases, if they're usually intubated, you want to try using the lowest tidal volumes tolerated, so 300 to 350 usually. And that's because you want to reduce the translation that's occurring with your images. So you want to make sure the TE probe is as steady as possible. And then later on, if you're using ice, same thing, that the ice is as steady as possible. And the anesthesiologists are really good with this. They work with us. And if they need to increase the PEEP, they will do so to maintain oxygenation. And so here's a case. Let's just walk through it. This is a 63-year-old female who had shortness of breath. She has an EF of about 40–45%. And you can see that her tricuspid regurgitation was calculated as massive. And it's secondary from atrial and ventricular dilation. And she has been optimized with a heart failure specialist and still symptomatic. And looking at her TR, I mean, you would guess that she would be symptomatic. I mean, it's pretty extensive and it's coming from the entire coaptation plane. So TR is coming clearly across the valve itself. And so we went ahead and we mapped this valve. And when we sweep through, again, it's important not just to see where the TR is coming from, but what does the tissue look like? What is the integrity? And here you can see that the septal leaflet is actually pointing downwards. So that's important to keep in mind, because if we're going to be clipping it, you got to make sure that you're actually clipping the leaflet tip and not getting it from the side or a side bite of the actual leaflet. So we went ahead and we would sweep through the entire valve, and you can see here that the TR jet is even more significant. And then as we get closer to the septal and posterior leaflets, there is some, but mainly this leak is all AS. And so it's all leaking from the anterior and septal area. So this patient going into the case, we knew it's going to be hard. We knew that it's going to be a couple of clips, but we were definitely willing to move forward. And so for completeness sake, this is her transgastric. Again, not everyone reads the textbook, and it's not ideal, but it's good, and you can work with this. So let's move forward and talk about how we build our MPR. And MPR is extremely important. This is a Philips system, and building the MPR from the mid-esophageal view, we start with a 3D zoom volume set, and then working red, green, and then blue boxes. What we do is we line up your blue plane in the red box first at the tricuspid valve leaflet tips. Then in the green box, you line up the blue plane again at the tricuspid valve leaflet tips. And then in our blue box at the bottom, we like to rotate our aorta to 5 o'clock. And that's something that we would do just for so we can speak the same language with our interventionalists. So I'll let it play again because it actually is pretty fast. It's a quick thing to do. So once you're in your multi-view planes, remember to lock your planes and orient your blue plane right at the tricuspid valve leaflet tips. I do it in the red box and the green box. And then once the blue box is selected, you'll get your crop plane, which you can use to go ahead and crop out any kind of RA artifacts out of your plane, and then you can orient exactly how you want your tricuspid valve to be. And so after you build your MPR, you can also take a look at the valve on ice. And we use ice pretty routinely for all of our TriClips. And if you have pretty good images with the ice, you're able to do the exact same thing. You're able to sweep through using your biplane cursor straight across the tricuspid valve to look at the leaflet integrity. And you're also able to build your MPR similar to what I just showed you on the previous slide. And so when we build our MPR on ice, here you can see exactly as I showed you previously, our MPR was built, and you can essentially grasp and do anything that you would do on TEE that you would do here with the ice MPR. And so our routine is for this patient, what we decided to do was the clip and zip technique because her TR was so broad and extensive. So our technique is once the clip is brought into the right atrium, we'll check the grippers, and that can be done on TEE, usually in the mid or distal esophageal, whichever view is the best. We'll use transgastric to orient the clip. And then we'll start grasping, and we'll grasp either on TE or on ice. But the thing for us is that if we grasp on TE, we'll always confirm with ice as well before we deploy. And that's just a double check that we like to do to make sure that we're not missing anything. We'll assess tricuspid regurgitation, and then we'll deploy the clip. So we'll do this as many times as needed for as many clips that are needed. And we knew that for this case, we were going to need at least more than one clip and probably up to 2 or 3 clips. And so when we start to clip, we will start at the anterior and septal commissure, and we'll move our way forward. If there is regurgitation at the P and S leaflet segment, then we can put a clip there. But for this particular patient, she had no leak there. It was all in the anterior and septal area. And so let's jump into this case. And here you can see on imaging, there is a wire up into the SVC. And I just wanted to point out the different images here. So this is your ICE catheter on the top right part of your screen. And down here, this is how a guide would look like. So it's the double railroad. The fat guide is clearly visible on TE. And you're going to be able to guide the proceduralist into the right atrium and then guide that clip towards the tricuspid valve. So you want to make sure that they steer away from the interatrial septum and also actually steer away from the right atrial appendage. So this guide needs to be pulled back so then when they bring in the clip, it doesn't interfere with the right atrial appendage. And so once the clip is into the right atrium, we will test the grippers. And here you can see on top the septal gripper being tested, and then on the bottom there, the anterior gripper being tested. And so after the grippers are checked, that's when we will orient the valve. And communication between the imager and the proceduralist is incredibly important at this point, especially for the first clip. You really want to make sure you land the first clip properly because the other clips, if needed, are going to follow the same trajectory. And so, you'll have communication, you need to clock it or counterclock it in order to align the clip perpendicular to the leaflet coaptation plane. And so once the clip is aligned, that's when we start to grasp. And for educational purposes, I'll show you TE and then I'll show you ICE. And so here, this is our TE images. So here you can see our clip was advanced into the right ventricle and now it's being pulled back towards the tricuspid valve leaflets. You can see that once the leaflets look like they were inserted, the grippers were dropped, and you can see a nice healthy bounce on the leaflets themselves. And then the clip was closed. At this point, before we deploy, it's our habit usually to switch to ICE. And so here are our ICE images. So this is the Philips 3D ICE, and you can see that the images are pretty good. And every patient's a little different. Some will have excellent ICE pictures and excellent TE, and some will have one or the other. So here you can see that this patient had pretty good 3D ICE images, and you can easily see, especially up here, that the leaflets are really well inserted into the clip. And then once closed, the leaflets came together rather nicely. And so this clip eventually was deployed. And when we check the clip after deployment, this is actually very good news. So here you can see that my biplane cursor is right through the clip. The clip itself looks very steady and there's no TR coming from that area. We expected residual tricuspid regurgitation adjacent to it. So this was, very satisfactory, and we went ahead to bring in our second clip now. And so when the second clip again is being brought in, your guide is again, manipulated into the right atrium, and your clip is brought in. And at this point, the proceduralist has a clip already at the tricuspid valve, so fluoroscopy guidance is also used. So they're able to guide the second clip close to the first one. And I believe the second clip for us was an XT here. Its first one was an XTW. And so you can see that the grippers are being checked, and after checked, then they closed the clip and we brought it into the right ventricle and pulled back to approximate the tricuspid valve leaflets and then closed the clip. So this is how it looked like on TEE. And then here it is on ICE. So exactly the same steps for this patient on ICE. And you're able to really see the leaflets well on ICE. Sometimes you don't see the bounce as well, but you do see leaflet insertion really well on ICE. And here at the bottom, you can see that after closing that second clip, the leaflets were very well approximated. We felt comfortable to go ahead and deploy that second clip. And so TR assessment, you can see we're zipping along here, and we've really decreased the TR. I'm kind of interested to know how many people would have stopped here. We'd like to keep going until we really have mild or less TR. So we thought that this is definitely more than mild, so we brought in our third clip. And so here's our third clip now. This is, I believe, an XTW. You can see the grippers being checked. And the same steps were followed. For educational purposes, I wanted to show you some of the transgastric images for this clip. And just as mentioned previously, transgastric can be helpful, not just for orientation, but for really checking to see if the leaflets were well inserted. And so if the leaflets come together and they're approximated at the center of the clip, then you know that you've grasped the leaflet tips and you're not biting from the side or side biting on the leaflet. And so we were very happy with how this third clip came. You can see how they were all aligned rather nicely on TEE and very parallel to each other, and color check at the bottom, really minimal TR was left. On ICE for that last clip, just for completeness sake, you can again see that the leaflets came together rather nicely here, and also with a very great improvement in tricuspid regurgitation. And so gradients usually are not an issue, but just for completeness, because we put 3 clips, I will show you. This is actually a gradient that we got on ice. But usually gradients the next morning are even lower. And again, usually not a main issue for this procedure. So just some lessons learned. T and ice imaging are used to evaluate anatomy and to guide the procedure and deploy the clips. You know, as an imager, you should be very comfortable in optimizing the patient beforehand. Really give yourself the best shot before you start, and feel comfortable with the knobology and know how to transition from T to ice and be comfortable going back and forth the imaging modalities rather quickly. In patients with large gaps, such as our patient, multiple clips may be required, and using that zip-in clip technique can be helpful. So with that, I wanted to introduce the next speaker. And we're going to be talking about optimizing for grasping and leaflet insertion. So Edris, take it away.
Thank you so much, Lucy. That was a wonderful, wonderful talk, and it actually is a perfect transition. So I'm going to be talking about optimizing grasping and leaflet insertion. Here's my disclosure slide. The outline of this portion of the talk, the last portion of this webinar, is developing your toolbox for grasping and leaflet insertion. And really, I'm going to give you our UC Davis toolbox. It's a ever-evolving toolbox. It's very different from the beginning of the TriLuminate trial. But typically, we like to grasp in dedicated transgastric. We do have an emphasis on alignment, given the number of scallops for the tricuspid valve. It requires a different mindset than MitraClip when you're doing dedicated transgastric grasping. We also will always then do transgastric MPR to confirm our grasp. If the dedicated transgastric looks odd, we will then use transgastric MPR to grasp. We also will assess chordal location even before the case using transgastric MPR. Gagan highlighted that really well. And it's a really easy next step. If you're doing dedicated transgastric, it's really nice to just go into MPR from there. Next step after that, we always check esophageal MPR. And after that, we use 3D ice if needed. And that's fantastic for grasping and leaflet insertion, as Lucy really highlighted well in her case. So here's our little toolbox map. It starts at 12 o'clock with dedicated transgastric. We then move to 3 o'clock with the transgastric MPR. 6 o'clock is our esophageal MPR. Last, we have 3D ice. And at Davis, we don't really do biplane grasping or dedicated grasping. Lucy actually gave really beautiful examples of doing it, and we did do it before. But over time, I guess our grasping technique and toolbox has evolved. And we felt like with biplane, sometimes we were worried, are we actually seeing the arms perfectly? And with dedicated grasping, you can do it, but you absolutely have to know, is this perfect? Can I see both arms? And often you can't get a dedicated grasp. You sometimes can for the first clip, but when you get to the second, third clip, it becomes harder and harder. There is a technique that I will highlight later on that will determine if you can get a dedicated grasp. So here's transgastric grasping. This is a very imager, implanter, communication dependent view and technique. So when we're doing this case, what happens is often I have a good transgastric. I actually tell Gagan, I'm not moving. I'm sitting right here. And he says, okay, when we advance the clip in, he knows he's just below the leaflet tip sometimes, or he's just there, like 2 millimeters below. So then his clip emerges from the darkness, as you can see on the left clip. And as it emerges, you'll see leaflet tips fall into the center of the clip. When he sees that and they're kind of stagnant in the center, he then will drop his grippers and you'll see the leaflets jostle. And as they jostle, they come into the middle of the clip. And this involves a lot of communication between myself and Gagan. There's a lot of, I'm not moving, Gagan. He says, okay, don't move, I'm coming up. And as he's coming up, he's moving into, and I am not moving at all. So it's a technique that really tells us how alignment is, and we've really fallen in love with at our institution. Here's an example, and actually Lucy gave really beautiful examples of transgastric dedicated, of leaflets not being engaged. So Gagan was coming up, and what you see here is the anterior leaflet is just fully moving. It's quite open. And the septal leaflet may be engaged, but I don't see it falling into the middle of the clip. So our next step when we see something like that is, if Gagan is seeing that and he says, you know, this looks a little bit odd, I say, don't worry about it. Let me go into MPR. So this is what we did next. So we said, okay, let's build our MPRs. So this is a transgastric MPR. I labeled it a little bit. So you can kind of see the top left, the left clip, the top left panel is your transgastric. Your RV inflows on the right upper image. And you can see in the blue plane, the bottom left image on the left clip, you can kind of see the anterior arm, and you can see the leaflet freely moving. So we just don't have engagement with that anterior leaflet. So when Gagan saw this, he's like, this makes me happy. I love this. So he immediately advanced the clip and engaged the anterior leaflet, which you can see in the right clip. You can actually see he's actually advanced, and now he's engaged both leaflets. They're falling in. And the second he saw that, he's like, I got to drop the grippers. We got it. So you can actually just grasp in transgastric MPR. It's not always a great image. That's why it's important to have a toolbox, because this may not always be there for you. If your probe is very far from the tricuspid valve on your transgastric, your MPR will suffer. So often with ice, that's an issue as well. If your ice is very far from the tricuspid valve, the quality, the resolution of your MPR suffers. So if you can get a good transgastric and it's quite close to your probe, the MPR will be really high quality. Here's an example now. We kind of tightened fully. We put color on. We feel really confident with this. Looks like we really have these leaflets in there. And when we have imaging like this and it's this good, often, after we've done our assess, because after we do this, we will still assess esophageal MPR. We'll always do dedicated. We go through our toolbox to confirm our grasp every single time. And so after we've done that, we may go transgastric again because we saw how good those MPRs were. And now we're planning out where should we put our next clip. And now I'm moving just central to the first clip, seeing on the left clip that there is color there. And on the right, I'm taking that color off and I'm looking at the leaflet lengths in that right upper panel on my right clip. And I can see the septal anterior leaflet there. There's some slight chords there, but nothing that'll make this a tough case. So the next thing we're going to go over is esophageal MPR, which I absolutely love. So here's an example. So here's an example of a case we did. We love doing dedicated transgastric. It's very different than MitraClip in that way. Here we have a RV lead in the septal posterior commissure, okay? And it's causing the shadowing over the actual tricuspid valve leaflets. So although it looks like we might have anterior septal and anterior leaflet, we're not sure about septal leaflet. There's this shadow that just comes across. So the question is, what do we do next? Do we do MPR off this? Is this grasp good? Is it terrible? Should I ask Abbott what to do? What is our next step? And in this case, because the MPR shows shadowing, because the transgastric shows shadowing, the MPR likely won't be good quality. So you have to go to a different position. So we moved along on our toolbox, went to esophageal MPR. I love getting it from a deep esophageal position. So I like to go to 0, see the leaflets the best. Then I increase my omniplane to get a really good RV inflow from the deep position because you're a little closer to the tricuspid valve. And then I build my MPR, as Lucy really showed well. And here what you're seeing is in the left clip on the right, the red panel, you can kind of see there's a gripper falling momentarily. And you can kind of see now we're going to slowly tighten. The right clip is the progression. We're tightening slowly there. So we love using esophageal MPR. It is absolutely in our toolbox. And here you can kind of see the sequence. Now we're tightening even more. We really feel like we got these leaflets. They seem very taut. They're falling in there. Beautiful highlight, whoever did that, thank you. And now we're putting color on just to show there's no color through there at all. And we did the same thing for our second clip. So Gagan mentioned this earlier. It's not the same for every patient. So some patients, their transgastric looks amazing. We just do dedicated transgastrics the whole way. Some patients, it's transgastric and then transgastric MPRs. And in some patients, the transgastrics are terrible. And in those cases, it's just let's do mid-esophageal MPRs. Now, we always confirm our grasp using the entire toolbox. So if we do dedicated transgastric, I'll do transgastric MPR, esophageal MPR. I'll even do RV inflow X-plane just to confirm my grasp. And we can do ICE too if needed. And so here's an example of the second clip. It was fantastic. And here was our pre and post with this esophageal MPR case. So, it was mostly central, a little bit SP, and then post, we really had maybe 1+ TR at the end. So now let's go over a hot topic everyone always asks me about, which is 3D ICE. So 3D ICE, I'm kind of going to go over a little case that we talked about once at CVI. So here's an example of using TEE to do trajectory on the left clip, and we're going to assess alignment as well using TEE. So that's kind of our technique. Because TEE gives you a broader view of the tricuspid, it works really well for trajectory and alignment. And then usually what we do is if we have the clip in there and we saw trajectory and alignment, we felt it was okay, we then will, if we know there's a case we're going to use 3D ICE, we then will bring out the 3D ICE catheter and we'll use this technique called 3D navigation. And with this technique, what we're trying to determine is what is our potential grasp angle? And you can use this technique with TE, with MitraClip, and with TriClip. And so what we're doing here is, if you look here, there's a -45, this left clip is a -45, and we're doing biplane imaging, and 45 is a potential grasp view. You kind of can see the arms, but not really. So what we do is we build an MPR, and your MPR planes are actual angles. So the right clip, the green plane represents -45, because that's what you built off of originally. And the red plane is 90 degrees off that, that's 45. And now you can kind of see our clip there and its orientation. So you know that the green plane is -45, you know the red plane is 45, and 0 is right there. So now you have an idea that, well, you know, if I go to 70 degrees or so, I likely will see this clip and the arms really well. So before we even advance in, we're going to check that. So here we are at 70, and here we're utilizing a tool in 3D ICE called tilt elevation. And what this is essentially that animation on the top is showing you, essentially what you're doing is you slice the valve at a certain angle, and you actually can sweep the valve at that angle, right? So usually us imagers, we're clocking the probe counterclockwise, rotating the probe. But with 3D ICE, I don't have the probe in my hand. And you know, Gagan is quite tired. He has to do the case. He can't do the case and do the imaging. At that point, I might as well leave the room. So what I'm trying to do is help my implanter out, make his life easier. So what I did here is we have 70, and I added 2 degrees of tilt on the left image just to see the grip, just to do a gripper check. And we're doing the same thing on the right. We're doing another gripper check. And so this is a very, very powerful technique that we should be using in 3D ICE. So now we actually switched off of 3D ICE in this case, decided to advance in an RV, and you can kind of see in the left clip, your biplane image is very good, in all honesty. There are many people who would use that to grasp, and that's fine. It's just not something our lab typically does. We have a toolbox, and we like to go through our sequence. And here we're doing a dedicated transgastric grasp in this case. And what the arrow is pointing out is that anterior leaflet is way too mobile. You know, so here you can see the clip emerge from the darkness, but what I see is an anterior leaflet that never is falling into the center of the clip. It's always outside the clip arms. So this is something of concern. So given that, and given that our 3D ICE looks so good, we said, look, let's just use 3D ICE in this case. It looks so good. We know it's going to have a good result. And this is why many places love 3D ICE, because it really does make grasping a lot easier. So here's an example. Here we kind of moved to 75 degrees because I felt like we saw it best there. The left clip is 75. I have -5 of tilt elevation on there. So you can kind of see the arms. You see the leaflets on the arms very nicely. And then we switched them 70 or so just because I thought maybe this might be better for the septal. And the gripper falls, and as Lucy mentioned, sometimes you don't see the grippers talking, is what we say in our lab. We like to use that kind of slang. And that is often the case with tricuspid leaflets. They're very thin. They don't have the girth of a mitral valve leaflet. So you don't see them talk as much when you drop the grippers. That is something that's very common. And what we did was, once we felt like we've confirmed everything with 3D ICE, we immediately go back to transgastric. And the reason we do that is because alignment is so important. Often there's more than 3 leaflets. There's many scallops. If you don't have good alignment, you can pull apart those scallops and cause more TR. And here the red arrow is pointing, showing you that this anterior leaflet is absolutely fantastic. Now we're going to do a conformation of our grasp. So here we actually went back to ICE. This was for teaching. This was for teaching for my fellow, and just showing that the anterior leaflet is quite taut. It's never falling below the clip. There's no color through it at all. And here's our pre and post. Ultimately, we put 2 XTWs in a mid-central SA position and a central septal posterior position. Mean gradient was 1. TR was substantially reduced. And that was a great case. And so for high quality grasping with 3D ICE, it's really important to really follow a few techniques, which is decrease your depth as much as you can to increase your resolution. Narrow the sector width, okay? Because you're really just focused on leaflets here. You don't need to see the entire view of the mountain. You're just looking at one little peak. So you really want to focus on the grasp. And an alternative option here, because here it's -45 and we biplaned it to get our 45. Another option is just, hey, just go to 45 degrees and use -4, because you can see the -4 there, of tilt elevation. and you'll get that same view. So, if you want to get even higher resolution image than this, you just go to 45 itself and you can get the grasp. So people often will ask, when should we use 3D ICE? Okay, so if you look at the Triluminate clinical trial, all of those cases had to have transgastric views and good mid-deep esophageal views, right? I think if you are doing 3D ICE and learning, you should learn from best cases where you have good TE views, and then you can understand how 3D ICE can be used, the correlation between the both imaging modalities. Then as you're learning with 3D ICE progresses, you can move from the best case to, I only have transgastric or I only have esophageal. Can 3D ICE be used in a solo? It can. We've done a couple of those cases. It's very difficult. I think Gagan will confirm that. So I think it's something that you really have to move from the left part of this slide to the right as you gain more experience. So here's a reference. We talked about 3D ICE navigation. This concept of 3D navigation, it's been published just this year by Madeira, myself, and Marcus, and Gagan. And I really think this is a good reference slide for others if you guys are interested in understanding that technique, which tells you what is my grasp view. And you can use this for MitraClip and TriClip dedicated view grasping. So in summary, you should be able to use all the options in your toolbox. You have to have a toolbox. You have to know how to use all the options because you don't know which one your patient's going to need. So in our lab, we do dedicated transgastric. To confirm that, we always do NPR off that. We always do mid-esophageal NPR. And if needed, we then will use 3D ICE. RV inflow with biplane is absolutely legitimate. People use that all the time. We don't in our lab, but it's something that you can use and it works well. Lucy gave a beautiful example of that. We love dedicated grasping too. That's actually how we first did our cases, but it was so difficult in some cases. And it wasn't as reliable to know, can I get a grasp view, that we kind of fell away from it over time. And I would highly recommend practicing 3D ICE on easier cases, then you can progress to the harder cases, and it helps you develop a workflow with your team. Sarah?
Thank you, Dr. Aman, and thank you, Dr. Singh and Dr. Safi, for taking us through that whirlwind of imaging, best practices, and multiple cases. I know it was a lot for you to get all of that packed into one webinar. It felt like 3 webinars in one. So again, thank you so much. We do have a few questions and we have some time. So I would love to hear from all of you for a couple of questions that we received. So the first one, Dr. Singh, I wonder if you could just address, grasping in the different views and transgastric versus going back to mid-esophageal. What is the sort of Abbott recommended workflow for grasping in tricuspid, especially for our newer implanters or those that maybe not quite as experienced as UC Davis team?
Yeah, and we've certainly evolved to where we are today, and we've it's taken us a time to get here. So I do think it's incredibly important that you kind of start off with kind of the way that we have done it and then try to incorporate some of these advanced techniques. And I think we've gotten pretty facile with transgastric, using the transgastric view as a grasp. But it's really important to take a step back and say, hey, the crux of the procedure is to see the grippers come down. The crux of the procedure is to see the leaflets fully inserted and then start to close. But you also want to, as Edris pointed out, respect the coaptation planes. Unlike the mitral valve and the tricuspid valve, even if you're off 5 degrees, because what happens sometimes is you've done your alignment in transgastric and then you go back to mid-esophagus and you have your X-plane on and you come back to engage, you could have rotated 5 degrees, or if you're having difficulty engaging both, your alignment is off. So I think it's so important to come back, do your alignment, and then come back and then see the grippers come down and leaflets fully inserted. And so some of that is the Abbott kind of recommended approach, especially for newer centers, is to kind of come back, see the leaflets engage the arms, and see the grippers come down and close in real time. And I think that one of the beautiful things that Lucy showed from her group is that this is the power of having 3D ICE. You can be transgastric, you can confirm your alignment, and then immediately press a button, switch to 3D ICE. And now you see the arms, you see the leaflets, and you see the grippers fall, and you can close all at the same time. So that's kind of the early approach. And then as you go through, there are some additional advanced techniques that we touched upon.
Wonderful. Thank you for talking us through that. And a question for all of you, could you explain a little bit how your approach to treating and imaging the tricuspid valve has evolved from the start of the clinical trial to, how you're doing it today?
I can start with that. I think, when we first started, I think these pre-procedural echoes, they are recommended to be done by the person that's actually going to be in the procedure. I think it's important that the person doing the imaging, doing the workup, the structural heart imager is the one that's involved, because continuity is important. These cases, these planning TEs can take about 40, 45 minutes. What we really do is we take our time and we map the valve. And, over time, I found that, I've learned, when to really take my time to really try to optimize pictures, and when to say, this view is not going to be a good view for this patient. I need to move on. And, another thing that I think has happened over time, especially during cases, is that we've gotten more and more quicker in terms of optimizing pictures, NPR, and really minimizing the up and down movements of the probe, to try to avoid trauma to the patient. And so, we really started to do these cases more efficiently and to use more and more 3D ICE as time has gone by. And so I think in terms of imaging, that's the trend that I feel like I've seen now that it's more and more commercial and we're doing more cases from trial to now. What about you guys at UC Davis?
Yeah, I actually totally agree with you. I think the importance of NPR cannot be minimized. I think that you have to be very proficient and fast at NPR, and MitraClip is your practice zone. And the screening cases are a great way to practice your NPRs. So I think that it's absolutely important to use NPR and learn NPR to, oh, sorry, I think someone's trying to open my door right now to my office. So I think it's absolutely important to use NPR and practice NPR and use it for the mitral valve. And then when you get to the tricuspid, you're much more proficient fast, and it'll make your cases so much better, and you're be much more accurate in terms of alignment, leaflet insertion, etc.
Yeah, I would just really quickly add that I've certainly seen just an evolution in all of our imaging groups. When tricuspid screenings were first done, it was done for whatever the ASE recommendation was. You kind of do everything in 0. You do everything and then do it with color. You do everything with RV and flow in 2D. Then you do everything RV with color, and so on and so on. And now when I see images coming from our screeners, they're actually thinking about the valve as an implanter. So when they're acquiring images, they're exactly where the TR is originating, and then they'll take color off to show me the grasp right then and there as the next clip. So that's a huge change that I've seen that has really helped us streamline our assessment of these valves and come up with a treatment strategy.
Wonderful, thank you. And one thing we like to point out here is we always like to show excellent, best case examples with our echo images, especially in a national webinar. But what if you're really struggling with a tough image and you're not getting a really good view? How do you turn that into a great image? Or if you're seeing tough imaging in the screening TE, how do you then prepare for the procedure?
I usually yell at my imagers, so no, I'm joking. Okay, I'll be quiet, please.
I'd like to, go ahead, Lucy, you go first.
Well, one thing I was going to comment is that you try to prepare for bad images. So when you're doing a screening TE, if the images are fantastic or if the images are subpar, what I'd like to do right at the end of the screening TE is flip the patient on their back. And I like to image them supine just to get a couple key images, and I'll document on the screen supine so I know what to expect. Because when you're in the TE lab, everything's gorgeous, everything's perfect, and then they get on the table downstairs, and all of a sudden, you have a completely different patient in front of you. So I do like to try to pre-screen patients with supine images. And then I did show a slide earlier about all the other techniques that you can do with the blood pressure cuff under the shoulder and optimize respirations to try to help. Sorry, go ahead.
Yeah, no, I totally agree with you. So I also, during my screening TEs, I will look at, and Gagan knows this, I'll look at the CAT scan ahead of time, and I will look at the relationship of the esophagus, the tricuspid, and the course. And so often I will tell Gagan ahead before the screening, this will be a really tough case. I will do this TE screening case versus my fellow potentially doing it. And I agree with Lucy totally, which is whenever we do cases, Gagan knows this, we put a pressure bag underneath the right shoulder, and I will tell them ahead of time, this case will be 3D ICE. That, we have an esophageal view, we can do trajectory alignment, but I think our grasping will be 3D ICE because we have very poor transgastric, or if our esophageal is very, very poor, we have transgastric, I'll say we can do trajectory and alignment, Gagan, but I think we'll need 3D ICE as well just to confirm leaflet insertion because our transgastric isn't optimal. So it's utilizing everything in your toolbox and then knowing when to, and over time as you do more reps, you know which one to take out for each case.
Wonderful. And then maybe one last question. Anything that you recommend people, not do, or things to avoid when it comes to imaging? Any common mistakes?
Wow. Do we have another hour to talk about that? I as an implanter, all I can say is if your first set of cases have to be where you have excellent mid-esophageal windows and you have excellent transgastric windows, and really you should try to stack up your first 3 to 5 cases that way, and certainly, again, as Edris mentioned and as Lucy mentioned, work your reps for developing MPR, dedicated imaging, and then not just the imagers, but the implanters as well, kind of understanding that language so then it's easy for you to go back and forth is going to be critically important. And then as you go through your experience, you will and guaranteed you will come across, if not tough windows, you will come across hardware. So patients who have pacemaker leads stuck in one section or the other, there's an RA lead. And so then steering becomes a challenging, imaging becomes a challenging. So things to avoid would be those kind of red flags, horizontal hearts where imaging can be challenging, especially once the device is in there. Stay to the side of good windows, not a lot of hardware, and then work your way through and ask for help, call for help. We can always kind of help guide across the country. There's many people that have even more experience than we do, and we call for help all the time, and that certainly gets us through those tougher cases.
Awesome. Any final tips for having an efficient workflow? And we talked about our whole kind of toolbox today. We can just kind of end on that note on leveraging all of those tools in your toolbox efficiently.
Practice knobology. I think that's extremely important. As an imager, I can say that if you're going to be, manipulating the probe and the machine, and then also doing ICE, know the knobology and practice your MPRs on, like as mentioned previously, practice it on the screening echoes. Even if you're doing, a T for a different reason, if they have TR, go through the images that you think may be needed and practice. And so if you understand knobology, that will help efficiency.
I totally agree with Lucy. I think that it's all about practice. Even for Gagan will know this, for our 3D ICE cases for left atrial appendage occlusion, we were practicing tricuspid imaging with 3D ICE on those cases because you're already going into the RA. So why don't we actually image the tricuspid and get our routine going? And that's actually how we really got more efficient and better. So when you're doing NET, I always evaluate the tricuspid. I always do MPR on the tricuspid because it just builds your muscle memory and it makes things faster in the OR.
And we've picked up additional patients that way too.
It's good for business.
Wonderful. Well, thank you all again. I think we'll call it, wrap it up now. I really, really appreciate you all three jumping on today, and for everybody attending. Thank you for your attention and engagement. So thank you again, Dr. Singh, Dr. Aman, and Dr. Safi. We hope you have a wonderful rest of your day.
Thank you.
Thank you.